hemorrhage is a risk factor for future AVM rupture, especially within the first year. Venous outflow obstruction, deep venous drainage, deep location of the AVM, particularly presence of arterial aneurysms. I'll say venous varices is a little bit controversial. There are some folks who plug this into their formula who say actually the presence of venous varices is protective against hemorrhage. We've seen hemorrhage from venous varices in the past, so I would say that that's controversial. And then arguably age, and just in the sense that the younger you are, the higher your lifetime risk of rupture. Again, the reason why we care about brain AVMs is because of their risk of rupture. At first rupture, there's somewhere around a 10% risk of mortality, and somewhere between a third and a half of people who have a first-time AVM hemorrhage will be dead or dependent within a year or two. And so this is very, very serious. And unlike intracerebral hemorrhage, which is shown here in the black, hemorrhage due to AVMs happens in younger patients. So these are patients who are in the middle of their career, who are raising young families. So it's particularly devastating. Obviously, the goal of intervention for AVMs is to obliterate the nidus. And when you talk to patients about intervention, you're really talking to them, what is the risk that this is going to rupture in your lifetime, and what is the risk of intervention? And if your risk of intervention is greater than the risk of hemorrhage in the lifetime, then you observe. And if the balance is the opposite, then I think it's fair and justifiable to offer intervention. Here are the interventions that currently exist in 2026. We have microsurgery, radiosurgery, endovascular embolization, and some creative combination of these things. We'll talk about them just briefly before we get into the AVM biology. But so microsurgery is obviously the gold standard for AVM resection. There's a high rate of obliteration. There's immediate elimination of hemorrhage risk, and it's durable, meaning if you truly resect the nidus, it's not going to come back. And we're all familiar with the Spetzler-Martin grading scale, and this is really a scale that predicts surgical risk. And so Spetzler-Martin is made up of the size of the AVM, the eloquence of the brain, the pattern of venous drainage, and the higher the number, the higher the surgical risk. And this is from the original paper in 1986. And what's fascinating about AVMs, particularly grade 3, to a lesser extent grade 2 and 4, but they are heterogeneous lesions. So you can have a small lesion with deep venous drainage that's an eloquent brain, and that's a grade 3, just like a large lesion in eloquent brain with superficial drainage. And you can mix and match all these criteria together to come up with a grade 3. And Dr. Lawton was really the first one to publish this idea of, within the grade 3, within the intermediate grade AVMs, there's actually variable microsurgical risk. And that led to the generation of the Lawton-Young supplemented grading scale. And so this is a grading scale that kind of mirrors the Spetzler-Martin grading scale. And so to AVM size, venous drainage, and eloquence, they add age, unruptured at presentation, and the diffuseness of the nidus to come up with a total score of 10. What they're showing here is that
to AVM size, venous drainage.
When you look at grade 3 AVMs and you add the supplemental scale, there seems to be a cutoff between a supplemented score of 6 and a supplemented score of 7, at which it becomes unsafe to offer resection. And in subsequent publications, Dr. Lawton and his group have shown that, again, a grade 7 is a predictor of poor microsurgical outcome. And this is not only true for grade 3 AVMs, but also grade 4 and 5 AVMs. So really getting at this idea that the supplemented scale is maybe a little bit more refined than the traditional Spetzler-Martin scale. But the reason I show any of this is just to drive home this point that only a subset of AVMs are amenable to safe surgical resection. There's an option for radiosurgery. Here we're depicting the gamma knife with the cobalt isosources, and they all center in on the target to deliver radiation. We think that this works by first causing damage to the endothelial cells, which subsequently there's a loss of feedback inhibition to the smooth muscle cells and the intima. This causes smooth muscle proliferation. And then you get kind of this thickening of the wall and hyalinization, and ultimately you get obliteration of the lumen of the blood vessel. And obliteration following stereotactic radiosurgery is actually also correlative with the Spetzler-Martin scale. So if you look at Spetzler-Martin grade 1 and 2 AVMs, just all together, you can count on about an 80% chance of obliteration. If you look at grade 3, it goes down to closer to 70%. And if you look at the high grade AVMs, grade 4 and grade 5, it's really a flip of a coin. It's about a 50% overall obliteration rate. And so again, radiosurgery is an alternative curative treatment option for AVMs, even AVMs that exceed the safe limit of operability. And radiosurgery altogether is quite safe, but there's a high non-obliteration rate, and there is this latency period, which we didn't really talk about. But from the moment that the AVM is treated with radiosurgery until the moment that it fully obliterates, within that window, within that latency period, there continues to be the same risk of hemorrhage, about 2% per year. And then, of course, there's endovascular embolization, and probably the biggest take-home point from this as an option for curative treatment of AVMs is that it's very, very controversial. Historically, it was used as palliative intervention or as a pre-surgical adjunct. But in the 90s, with the introduction of liquid embolic agents, this led to an interest in embolizing for cure. We're all familiar with the Aruba trial, which took patients with unruptured AVMs and randomized them either to observation or best medical management, which essentially is observation, versus intervention of the treating physician's choice. And the risk of intervening in an unruptured AVM was too high, according to this study, to justify intervening. Well, part of the problem is that over half of these patients went to the endovascular suite with the goal of curative embolization. What we have learned is that when you take patients to the endovascular suite with the intent to cure an AVM, it has a very low overall cure rate. Some studies, this one that was recently published in 2023, showed that only about a third of these patients actually achieve the goal of getting cured. And there's a very high risk of complications, whether that's intraprocedural complications, post-treatment deterioration, or up to a 1 in 10 chance that you're leaving the angio suite, now dependent on someone else for your activities of daily living. This is true even in the transvenous approaches, not just the transarterial approaches. There in properly selected AVMs, there seems to be a higher rate of obliteration and treatment success with transvenous approaches. But again, if you look at this, 40% new neurological deficits, 30% procedural complications, 20% chance that you're, newly disabled or dependent after the treatment. And if you look at this in systematic review, again, a decent number of these patients don't even complete their intended treatments for curative embolization. And so overall, you're still getting a less than 50% chance that you're going to actually cure the AVM. using embolization. And without going through all this data, there's very high risk of complications, leading the authors of this particular review to conclude that given the high complication rate related to primary embolization, curative embolization of AVMs should be considered an unanticipated goal of such therapy or unanticipated benefit rather than the goal. And this is similar to what Solomon was saying in his talk. So again, the take-home points: low cure, high complication rate associated with endovascular embolization. This is obviously lesion-specific and operator-dependent. You're going to hear folks say, that's not my experience. And I think that's kind of similar to us using, Dr. Spetzler's data for AVM resection. Most of us aren't Dr. Spetzler. So we have to be real about our own experience, either with microsurgery or endovascular techniques. This is a little bit of my editorialization. I think it's currently still best used as a preoperative adjunct. Some people would argue for pre-radiosurgery adjunct. I don't think that that's really been borne out in large studies. But again, what we're currently able to offer patients is microsurgery. But again, we said only a subset of these are amenable to a safe resection. Radiosurgery, recall, up to even half of these, depending on the Spetzler-Martin grade, don't obliterate. And there's sometimes a 3 to 5 year latency period with a persistent rupture risk. And then endovascular embolization obviously has a low cure and high complication rates. And so the lack of targeted medical therapy, I would argue, is really the glaring hole in our armamentarium against treating brain AVMs. And historically, this has been limited by our lack of understanding of the molecular biology, the pathophysiology, the genetics of AVMs. But there was this groundbreaking paper in 2018 from the group out of Toronto. Solomon also gave the Toronto group a shout out. So they're doing something right up there. But basically, they discovered that about 2/3 of patients with sporadic brain AVMs have mutations in an oncogene called KRAS. And serendipitously, these are the same mutations that are found in the vast majority of solid tumors with KRAS mutations. So the oncology world has actually created a lot of tools for the diagnosis, and at least they're working on treatments of this. KRAS is a small molecule GTPase, so it signals from RAS through RAF, MEK, ERK, and then it translocates into the nucleus to turn on gene transcription. This group from Texas down here in 2021 generated a mouse model of this KRAS G12V mutation, specifically in brain endothelial cells. It was a very elegant technique. They showed that they were able to upregulate the transgene specifically in the brain, and then it co-localized with a marker of endothelial cells. They were able to grow these small AVMs all over the mouse cerebrum. You can see these are the blue latex injections. These are the MR angiograms from the mice. But they're pretty reproducibly able to grow AVMs in these mice simply by turning on this KRAS G12V transgene within the brain endothelium. These mice get spontaneous small intracerebral hemorrhages as a result of these brain AVMs. And again, we talked about RAS signaling through RAF, MEK, ERK. Well, there actually are inhibitors of MEK. One of the most commonly known ones is trametinib. And so when the group turned on AVMs and gave trametinib at the same time, they were able to blunt the formation of AVMs in the brain. And this was actually reproduced recently in the New England Journal of Medicine for these KRAS G12C mutations. So if you activate this mutation or this transgene in mice, they grow AVMs everywhere, including in the brain. And when you treat them with a medication called sotorasib, you're basically able to prevent them from growing these AVMs, again, when it's given at the same time that the transgene is turned on. And of course, it wouldn't be a New England Journal of Medicine paper if they didn't have some clinical correlations. So here are two patients with soft tissue facial AVMs with a known KRAS G12C mutation, and they were able to shrink the lesions using sotorasib. And so again, so what do we know? Well, we know that about 2/3 of sporadic AVMs harbor activating KRAS mutations, and that these gain of function mutations are sufficient to induce AVM formation in mice, and that inhibition of this RAS, RAF, MEK, ERK signaling pathway called the MAP kinase pathway, it prevents KRAS-induced AVM formation in mice, but there's no identified therapeutic modality to treat established AVMs. And so we sought to explore an innovative therapeutic approach for hemorrhagic AVMs using an engineered mouse model with a titratable KRAS G12V transgene. And we use both inhibition of MAP kinase and of the vascular endothelial growth factor, or VEGF pathway. And so we use a very similar approach to the group in Texas, where we use this endothelial targeting capsid protein to deliver an oncogenic KRAS specifically to brain endothelial cells. What we did is we added green fluorescent protein to the end of this so that we could hopefully track these cells in real time, that we could isolate them on a single cell level later on down the line. Again, we showed that our transgene co-localized with a marker of endothelium, specifically in the brain. And we first asked whether we could just reproduce the brain AVM phenotype that was reported by Park et al. In the Texas group. And so what we did was we gave 5 times 10 to the 10 genome copies per mouse of this virus to deliver the KRAS transgene to the brain endothelium. And we wanted to do non-invasive imaging at 4 weeks and at 8 weeks, and then we were going to sacrifice them. And at 4 weeks, everything was going really well. We did these T2 weighted MRIs, and the mice where we're trying to grow AVMs, you can see these little kind of hypo-intense rings with these maybe iso-intense or hyper-intense centers that grow in 100% of the mice that got the transgene, but then they all started to die, and that wasn't supposed to happen. And when we looked at the brains of the mice who were dying prematurely, they had hemorrhages everywhere, macro hemorrhages, micro hemorrhages. I mean, really too numerous to count. But we were able to find that grossly they were growing AVMs, and you can see AVMs are scattered just all over the brain of this mouse that was found nearly dead. And so at the end of our pilot study of 4 or 5 mice, we only had 1 mouse that made it to 8 weeks, and we were able to do a time of flight, MRA, and actually visualize an AVM in the mouse. And so this led us to ask whether the transgene burden of the KRAS oncogene might influence the brain AVM phenotype. And so we took a cohort of mice. We gave them either that 5 times 10 to the 10, 10 to the 9, 10 to the 8, or 10 to the 7 of the virus to deliver the KRAS oncogene to the brain endothelium. And we found that indeed, there was a dose-dependent response of the T2 lesions, and what we'll see in just a second, the bona fide AVMs, to the amount of KRAS transgene that was actually delivered to the mice. So again, here are the T2 lesions over time with each of the different doses. This is the quantification of the T2 lesions over time. These are the bona fide AVMs that we saw in MR angiography. And interestingly, overall survival was also impacted greatly by the transgene burden. And so what we sought to do at that point was actually grow AVMs and then give them certain drugs, either trametinib to inhibit MEK, RMC 7977 to inhibit KRAS, or basically mouse Avastin or some combination of a MAP kinase inhibitor and of anti-angiogenic therapy. And when we inhibited the MAP kinase pathway individually, we didn't really see that dramatic of a result. Maybe with the trametinib, you got a very modest prolongation of life when you treat or when you inhibited KRAS itself, there was really no benefit there. Interestingly, when you gave the anti-VEGF antibody, you actually had worse overall survival in the mice with AVMs. We can talk about that at the end. There are a lot of potential reasons, but when you combine the two, you actually get a fairly remarkable prolongation in survival in these mice with hemorrhagic brain AVMs when you inhibit both angiogenesis as well as the MAP kinase pathway. And if you look at the MRIs and you count these T2 lesions from 4 weeks to 8 weeks, you can kind of see that once you give them the medications, you almost press pause on what their brain looks like in terms of the number of T2 hypointense or early AVM lesions. And so we concluded that the KRAS mutations in brain endothelial cells are causally implicated in AVM rupture in a dose-dependent fashion, and that dual inhibition of the MAP kinase pathway and VEGF signaling may be a promising novel therapeutic strategy for KRAS mutated AVMs. I will very quickly, in 2 minutes, talk about another project that we're working on. Using this mouse model, we got interested in asking, how do sporadic brain AVMs form? And I won't go into this, but there are multiple theories on brain AVM formation, frankly, evidence for all of these. You can have congenital AVMs or what are called primary. They can be a part of a syndrome, or they can come de novo. And the de novo AVMs are very well documented in the literature. But really the mechanisms by which somatic KRAS mutations lead to AVM formation are totally unknown. And so we wanted to characterize AVM progression in a cerebral endothelial specific KRAS G12V mutant mouse model. So the same mouse model that we just used. Instead of giving them that 5 × 10⁻⁻⁻ dose of the transgene where all the AVMs grow and then blow up and then the mouse dies, we gave them the lower dose. So still 100% penetrance of the brain AVM phenotype, but they tend to live a lot longer. It's a much more benign phenotype. And we selected predetermined time points. We sacrificed the animal, we perfused the brain using microfill, and then we did direct observation and high resolution micro CT. And we basically characterize vascular abnormalities at each time point. And you can see here that as time goes on, you start forming these small AVMs. They're associated with a little bit of hemorrhage, and then they just grow crazy out of nowhere. And there are microhemorrhages. And you can see this much more clearly on the micro CTs. And again, this is just the red signal is basically the microfill, but you can see the progressive increase in both the number and size of AVMs over time to the point where by 20 weeks, they're almost taking over the entire brain. And, we kind of theorized, how do we think an AVM might form? And then we went and we actually investigated that. And what we found is you kind of get these small arterial outpouchings that form. They start to undergo early neovascularization or neoangiogenesis. They form an early nidus and they recruit a feeding artery. Ultimately, they recruit a draining vein, and then they become these large, complex, well-organized AVMs that, at least in this mouse model, continue to grow. Interestingly, things are pretty boring up until the 6-week time point in our mouse model. And from 6 to 8 weeks, things just really progress in terms of the number of AVMs, how diffuse and complex the lesions are. And so this has led us to predict, or at least theorize, that there may be some kind of a time-restricted switch in AVM pathogenesis. And so in the cancer literature, they talk about this as being the angiogenic switch. And I would postulate that potentially there's an angiogenic switch in brain AVMs as well. And just to remind you, this was an example of what our 6-week mouse looked like, little tiny AVM here, these microhemorrhages, and by 8 weeks, they've got AVMs, really everywhere. I know we're running out of time, so I'll just zip through this real fast. KRAS mutations are sufficient, not necessary for AVM development. You don't need a second hit. You don't need a high flow AV fistula, VEGF overexpression to grow AVMs in mice. KRAS mutant brain AVMs reveal 4 distinct stages of AVM development: aneurysm-like outpouching, early neovascularization, arterial malformations, and then AVMs. And then it's led us to a lot of interesting questions, which we need to answer in the future. I think there's a very interesting question about brain AVM initiation versus progression, and whether this time-restricted switch is because of hemodynamics or angiogenesis or both. And that may impact the timing of intervention. And so again, the final slide here, current AVM interventions are insufficient to treat the gamut of disease we encounter. That's what I tried to prove to you through the limitations of microsurgery, radiosurgery, and endovascular embolization. But genotype-directed pharmacotherapy may be another promising tool that we can add to our AVM toolbox. And understanding AVM pathogenesis may help us refine these novel AVM treatment strategies. This is the team whose work that I showed from my time at the Mayo Clinic, really a world-class group. And then if there are questions, comments, or you want to get a hold of me, this is my email address. So I'll stop sharing.
Thanks, Ryan. It's really quite an exciting time based on what you have shown. And, going back to the AV shunts in children and how that can help us understanding the pathophysiology and biology of AVMs. Yes, there is this issue in children of there is a definite risk of AVM recurrence after complete surgical resection, and it's something that we see clearly up to the age of 18, and it's not a phenomenon that you see in adults. It's also something that you see after surgery, but you don't see it after radiosurgery. So that led me to think and hypothesize that the surgery doesn't takes out the actual AVM, which is the phenotypic expression of something that is going on in that area, but it doesn't do anything to that process that was somehow initiated, while maybe the radiosurgery, which targets the nidus, but also has some, side effects in a way to the surrounding parenchyma, might actually stop and kill that something. And that's, as I say again, how to connect our clinical observation with the, furthering better understanding. And
yeah, I mean that's fascinating, because I mean, just like a tumor, which has a microenvironment and crosstalk between the tumor and the microenvironment, the AVM has a microenvironment, and there's absolutely crosstalk there. And even endothelial progenitor cells have been found in the microenvironment of AVMs. There are inflammatory cells. I mean, it's a very complex environment, as you've alluded to. And the thing I keep coming back to is a single mutation in a single oncogene, instead of causing cancer, causes this crazy malformation of blood vessels. There's some connection between KRAS and dysregulated angiogenesis that we don't understand. I mean, it's this whole process. So I mean, all that to say, I think you're absolutely right.
We have Dr. Gelos, who has a question for Dr. Ushi.
Yes, thank you for your wonderful presentations, and thank you, Professor Soliman. So I'm a medical student, first of all. May I ask you, in target pedicle embolization, how do you monitor or manage potential changes in venous pressure or collateral requirement between embolization and surgery to optimize safety and nidus collapse? Thank you.
Yeah, Thank you, Maram. That's an excellent question. I think there's two things to focus on. It starts with the actual embolization, right? You don't want to overdo it, embolization, and you do what's necessary. So, give you an example. If you have a stage or a grade 3 arteriovenous malformation, you're truly trying to downgrade this mostly to a grade 2 to make surgery safer. And by what I mean by that is if you envision an AVM located sort of in the occipital region, you're going to have usually flow coming from deep PCA feeders, and you're going to have flow coming from MCA feeders that are very superficial. So the goal for something like this is you want to take out the deep feeders from the arterial side. Those are the feeders that you won't encounter until you're deep into the resection, and they're going to be more challenging to get. So the goal is to take those out completely with the goal of making the surgery safer. And then you don't necessarily need to take out the superficial feeders because as soon as you remove the bone, they're going to be right in front of you and you can cauterize those. So this achieves two things. One, makes the surgery safer and a little bit easier for the surgeon. And two, you're reducing flow substantially, but you're not shutting down the flow so much to where you worry about this AVM thrombosing overnight before you take the patient to surgery, right? So you want to maintain just enough flow in the AVM, that way it doesn't spontaneously thrombose. Overnight, what you do, you obviously watch them in the ICU, you make sure their blood pressure is adequately controlled, you make sure the patient is well hydrated, right? Because you don't want to tip them over the edge and help this AVM get thrombosed overnight. So those are things that you got to have to take in mind or take into account when you're treating these patients.
Also,
Thank you very much.
The timing, was a, you don't want to do the embolization far in advance, because if you take a pedicle, proximal pedicle, then you might encourage recruitment of finer, smaller vessels from the surrounding tissue, and which is something we see in the AVMs that have been treated with the goal of cure, where cure was not achieved, and then you have these residual AVMs where there are a lot of secondary tiny little vessels all around it. There is another question for Dr. Goran Sami.
Hello there. Thank you for everyone who put the effort to be here. And I have a question to Dr. Solomon. You mentioned that you use catheterization of the venous sinuses. I had a question, and I'm a new neurosurgeon, a resident actually, about how do you control the hemorrhage when you do catheterize the sinus, and what are the measures that you take to prevent air embolism? Thank you.
So you mean direct, how do you prevent, so basically the question is, how do you prevent hemorrhage from direct surgical exposure of the sinus as you catheterize the sinus and then remove the microcatheter, and then how do you prevent the risk of venous emboli?
Yeah, that's an excellent question. So obviously the sinus is going to be arterialized, going to be pressurized. So it's not like your standard surgical approach where you want to make a big opening in the sinus. You're essentially cannulating the sinus and using the same techniques that you would use for endovascular approaches. So it's not that you're making a big incision in the sinus and inserting your catheter. No, you're just poking with a needle. You're confirming that you have backflow. And anybody who's familiar with endovascular technique, the Seldinger technique, where you get your needle, pass your wire, and then take the needle out, and over the wire, place your sheath. So the whole process, you're only maintaining just enough opening in the sinus to insert your devices so you don't have bleeding around them. And the other thing is you're always maintaining, good endovascular technique, meaning you have backflow, and then the sheath, once you insert the sheath, it's pressurized with saline that's heparinized. So that's how you maintain or prevent air embolus from happening. And at the end, there's a lot of endovascular closure devices that we use. So we can use that for the sinus as well. There's something that I personally prefer. It's called AngioSeal. And what it is, it's a collagen plug that as you're moving the sheath, you insert this, closure device, and it places a plug on the inside. And then the outside, there's also a separate component that sandwiches the sinus shut. So that's something that you can employ, and that helps you prevent any serious hemorrhagic complications.
Thank you. Any other question or comments?
Yes, I want to ask Professor Ryan.
Yep.
Yes, thank you, Professor Ryan, for your excellent and wonderful presentation. It was very clear, such impressive achievements. So may I ask you, based on your data suggestion, dose-dependent KRAS effect and the possible time-restricted angiogenic switch in aneurysm pathogenesis, do you envision a future therapeutic window where targeted molecular therapy could be used preemptively to halt aneurysm maturation before radiological or surgical intervention becomes necessary? Thank you.
So your question is, do I envision, based on this hypothesis of an angiogenic switch, do I envision a therapeutic window around that?
Yes.
Yep.
Yeah.
Yes.
It's a brilliant question. Unfortunately, the answer is that's a really good strategy in the lab. But as you know, patients don't come to you and say, I think I might have an AVM in a year. Can you please monitor me? Right. So that's not a practical approach clinically. But I think it helps us understand the disease process. And the more that you understand the disease, then the better your treatments are, or the timing of treatment or whatever. So to answer your question, yes, that's part of what we need to do in the lab. Unfortunately, that's probably not a great strategy clinically, just because it's not really practical. But I think the way that you're thinking about it is exactly the right way.
Ryan,
Thank you very much.
What do you think is the reason for the difference there has been some response in facial and um, um, cutaneous AVMs to medical treatments, but yet we have not seen the same degree of response and that I'm aware in brain AVMs? Is it because not all AVMs they might look the same under the microscope on H&E, but they're not all created the same?
Yeah, I mean, that's certainly one theory. I think realistically, there's just been more soft tissue AVMs that have been treated with these targeted therapies. People have figured, you can biopsy a facial or an arm AVM a heck of a lot safer than you can biopsy a brain AVM. There are scattered reports, I mean, less than 10 of CNS AVMs being treated with molecular therapies. All but one or two, I want to say, have been actually in the spine with these large kind of metameric AVMs that just happen to have some effect in the spine. There's really only one or two that I'm aware of where people have treated brain AVMs with these targeted therapies, one of which was in a child at Phoenix Children's. That AVM was not biopsied. There certainly were changes, but there were some ischemic off-target effects of treating the patient with trametinib, so I think they stopped treatment. But the risk of biopsy is so high in the brain, the risk of ischemic complications is so high. I think until we have a really good justification for doing this, I think we have to use the soft tissue AVMs as kind of our model.
Thank you. Thank you to the speakers for a very informative and thought-provoking section. Thank you, Dr. Requejo, and all the colleagues that have joined us. And I think we can conclude here.
All right. Take care. Thanks.
Yeah, thanks everybody for participating.
Yeah.
That adds to the corpora of neurosurgery education.
Thank you so much, John, for making this possible.
Well, it's always a pleasure.